I'm your host, Mark Plaster, and my co-host is J.D. Landon. Our guests today, we'll get to them in just a minute, are Allison Cohen and Dan Ralston. Am I pronouncing that right, Dan?
Yep.
Ralston? Okay. We're going to get to them in just a minute, but I want to set this up a little bit. As I was telling them, I'm an old dog, and the ultrasound issues are somewhat a new trick for me. Just to kind of give some framework for this, when I was writing the book Night Shift, I did a brief analysis of approximately how many patients I had seen over the course of my career. We came out to about 165,000. And so when I read your research on comparing manual pulses and Doppler ultrasound and its effect, I kind of got a flashback, and I asked myself, I wonder how many times over the course of my career I have said the words, "Pulse check, please." You know, it would have to be thousands upon thousands of times. And the real question is, do I really trust the information that I got? And what you really showed in your research is maybe there's some questions about that. And so I'll let you get to the meat of that research in a minute, but I'd like to hear a little bit more about you guys personally. I'll start with Allison. Tell me a little bit about you, and then Dan after that.
Sure. So my name's Allison Cohen. I am currently ultrasound faculty at North Shore University Hospital. I've been there for the last probably about 9 years. I currently co-run the ultrasound fellowship there as well. And I did my fellowship at Hartford Hospital in Connecticut. And I guess you could say my interest really is in ultrasound.
Yeah, and just a little perspective on Northwell. If our viewers are not familiar with Northwell, one little tiny factoid about Northwell is they employ 81,000 employees. It gives you the size of Northwell in the New York City area. So this is not a small facility.
Definitely not.
Dan, tell me about yourself.
My name's Dan Ralston. I'm an emergency and critical care physician. I did anesthesia critical care training at UCLA, and I did emergency medicine residency at St. Luke's Roosevelt, which is now called Mount Sinai West. And I've been at North Shore University Hospital since 2016. And also, my big interest is in critical care and cardiac arrest research, and kind of incorporating ultrasound into critical care research.
Cool. Well, I want you to review your research paper that caught our attention, actually caught JD's attention, and I'll just review the facts of it, and then I'll let JD take it from there.
So the abstract that we're going to talk about today is from, actually, it's a little bit of an older article in 2022, Resuscitation. And it looked at comparing femoral artery Doppler ultrasound versus manual palpation as for pulse checks and cardiac arrest. I actually think I saw you guys talk a little bit about this at AIUM years ago. We were talking about that before. And the second I heard you mention it in a poster or abstract presentation, I was like, oh man, this is great. We need to follow up on these guys. Because for years now, until I just recently moved back to our academic hospital, we didn't have A lines. Like literally it was like a hospital policy. You couldn't get A lines in the emergency department. We could physically do them, but the nurses weren't trained. They didn't have the materials. And so if you didn't want a manual pulse check, what was your other option, right? Nowadays, Mark, we're doing transthoracic ultrasound and diagnosing pseudo-PEA is this kind of new terminology. But then the question is, well, what do you do with that exactly? And when do they go from pseudo-PEA to actually having ROSC? And so that's why I thought this question of can we use femoral artery Doppler ultrasound to have a better understanding? And so what these guys did, I love this paper, is they took 54 patients. It was a cross-sectional, so they basically did independent variables of 213 pulse checks, and obviously you guys are going to correct me if I'm butchering this. And they basically looked at the accuracy of manual versus using peak systolic velocity ultrasound Doppler in all patients in cardiac arrest who also had femoral A lines, right? So the femoral A line is your gold standard, and then they were able to then go back and compare. So then you were able to then go back and use your femoral A line as your comparator to then look at manual pulse of the femoral artery versus the peak systolic velocity using Doppler ultrasound. And what I thought was really cool what you guys then did is then they answered the next question, which is what's the exact peak systolic velocity at which point you can correlate to about a 60 millimeter of mercury systolic blood pressure on the A line, which is beautiful. It's like answered all the exciting questions. And what they found, as you would expect, is that 95.4% of the time Doppler detected a pulse versus about 54% of the time for manual palpitation. And so right there, I mean, it's, manual palpitation, as you and I have talked about, Mark, is about a flip of a coin of whether you're getting the right answer to your question. And so that's exciting. Let's start out with telling us kind of what was the motivation, what was the initial inspiration to even go through the effort. I mean, 54, it was a convenient sample, but still 54 cardiac arrest patients getting the data, getting the images is a pretty large sample size for cardiac arrest research.
Yeah, and with A-lines in them and in the midst of COVID, it was fun times.
Yeah.
Yeah, I mean, Allie and I have been doing research together for several years, and we saw a paper that came out looking at color ultrasound for pulse checks and cardiac arrest. And the big thing we were concerned about was we didn't know, like, the gold standard was kind of, there wasn't a gold standard. It was what the clinicians thought. It was the transthoracic ultrasound, those things. And so what we found we really needed was an A-line to be in place for these people. So with an A-line in place, that would be a really good gold standard for this. And then me and Allie started talking about using Doppler ultrasound to then detect pulses and doing pulsed wave Doppler ultrasound. Okay.
What I'm going to ask here is, for those of us who are not ultrasound savvy, or let's say didn't do an ultrasound fellowship, can you break down kind of what are you doing when we say peak systolic velocity with pulse wave Doppler? Break that down for us. What probe are we using? What's going on with the machine? What does that mean?
So what we basically did is when patients came in with cardiac arrest, we took a linear probe because that's the highest frequency transducers. That's going to give us the clearest picture for a lower depth vessel that we're targeting. We would look for both the femoral artery and the vein, and then we basically would turn on the color just to confirm that it was artery versus vein, and then turn on spectral Doppler and basically take the indicator and put it in the middle of the vessel. And what we did was we looked at, whenever we did our images, we looked at them in a transverse view, which is basically cutting it in a short axis. And the reason we chose that is because we know a lot of Doppler ultrasound literature is done in long axis, but what we soon realized after doing this on a couple of patients is that your hand is going to be moving up and down no matter how hard you try to keep it. Yeah, no matter how hard you try to keep it still, it's going to move. And what we notice is that the femoral artery and the femoral vein with compressions have very similar patterns. So they both look arterial. So it's super easy to make a mistake when you're in long axis. So we basically did everything in short axis. And we would put the indicator on vascular settings. So everything that we did was on vascular settings. We didn't touch the settings or try to change the kind of the functions of the machine at that time. And we would put our indicator in the middle of the vessel and then turn on spectral Doppler. And when you do that, it basically gives you a tracing of a waveform. And what we looked at was the peak systolic velocity, which was on the y-axis, the highest that it got when we did a pulse check. And that's what we measured as the peak systolic velocity.
I love that. And then it's a little bit of a technical question. When, like, in the process of all this, because I started, as honestly, years ago, as soon as you guys presented at AIUM, I started practicing and doing this on my cardiac arrest patients just out of curiosity, really. Because, like I said before, a lot of our shops don't have A-lines, and so there weren't a whole lot of other alternatives. There's a lot of movement, particularly if you're doing manual CPR. Were you having your residents and fellows recording your spectral Doppler before you stopped CPR, and then you just kind of readjust your indicator to make sure you're in the vessel?
Yes. So we did it during CPR, mostly to make sure that we didn't interrupt or delay the pulse checks, because we want to make sure that whatever we were doing wasn't going to interfere and cause a longer interruption. So we would basically put the probe on in the inguinal canal, find the femoral vein in the artery, and then turn on the Doppler in the femoral artery right in the middle as best as we could. And then we would record the entire time. So right prior to a pulse check and then during a pulse check, so that we really made an effort not to interfere with anything that was being done to manage the patient.
Oh, that's interesting. So you had a little bit of data of what was going on in the femoral artery on Doppler during CPR as well.
Mm-hmm.
And
Yeah.
did you like see a noticeable change in your velocities, I imagine? I hope.
Yes. Yes, there's definitely, I mean, we're going to be looking at that in the future too. We're actually doing a study looking at that now currently, is looking at the velocities during CPR to try to correlate that with the compressions. But yes, we definitely did it before and then after, just to ensure that we would see tracings pre and post.
Interesting.
Allison, we had a podcast not too long ago looking at transesophageal echo during CPR, analyzing hand placement and that sort of thing. And obviously that would be a gold standard for looking at outflow tract and that sort of thing, which is really kind of a proximal measure of what you're looking at in the femoral artery, if you're looking at the aortic root and the outflow there. But would you guess, or do you think that looking at the PSV, you think that's a stand-in for looking at cardiac flow coming out of the aortic root? I.e., what I'm asking actually is this a poor man's way of telling how good your CPR is?
Yeah, that's what we were alluding to, and that's the research we're trying to do now, is essentially comparing systolic blood pressure that's generated on an A line to peak systolic velocity generated during chest compressions and end tidal CO to see if peak systolic velocity is really an accurate predictor of chest compression quality. So that's, hopefully you'll see something come out from us in the next year on that.
Oh, that's exciting. That's a teaser. That's a teaser.
Yeah, that. Obviously we don't want you to find what you're, just kind of prove yourself. But at the same time, are you assuming, or is your hypothesis that it is a good stand-in for, transesophageal echo?
I mean, I think that's what we're hoping for based on what we've seen previously. Is we've kind of been looking at the data. It's far from clean in terms of, but we've analyzed some of it, but not all of it. So it's hard to give you an accurate number of what it's going to be. But we've definitely seen, because we love TE and we do it on a lot of patients, but it does require a lot of advanced skill to do the TE. So
Sure.
I think having a surrogate for that would also be very helpful, especially in other institutions where you don't have as many proficient sonographers that can do the TE. But what we've seen is you've definitely seen changes in your peak systolic velocities that correlate when the arterial pressures during CPR are less than 100, for example. We've noticed that peak systolic velocities tend to be much lower, and when the compressions are better, using an arterial line, we've noticed changes in the arterial line, in the peak systolic velocity as well. So they have been correlating. The exact numbers I don't know yet, but that we have seen that they seem to go together with arterial line and peak systolic velocities.
That's exciting. That's exciting work. Now the unspoken question here, and JD and I were talking about this before you came on, and that is, how do you think that the systolic velocity is going to relate to diastolic pressure?
Yeah, we were talking about this too beforehand. Trying to think of questions you were going to ask us. We decided to use systolic blood pressures because it's, cardiac arrest is pretty chaotic, and often the blood pressures are very low in those situations. Sometimes you don't even get a reading on a diastolic blood pressure on the A line. You'll only get a systolic blood pressure reading on the A line first off. So we didn't really think we could use diastolic blood pressures. And then we were trying to figure out whether, Doppler flow, like peak diastolic flow, if that would peak diastolic velocity, if that could correlate. But those numbers are just so low. The flow, we've looked at some of our ultrasounds, and because the pressures are so low and the flow is so low, you really don't see much flow there at all. It's like 0 to maybe 3 or 4 or 5, something like that. So we didn't think we could use that data very reliably, and it's really just hard to see on the y-axis of the ultrasound machine how high the diastolic flow velocities are.
I mean, the hard question here is, are we fooling ourselves by thinking that the systolic peak velocities correlate with successful resuscitation?
I mean, I think it's hard to tell. The only thing that we're using right now is the A line. And so we're trying to correlate what the blood pressures are on the A line with the quality of the CPR with TDE as well. So when we're noticing that we have LVOT obstruction when we're doing compressions, because many of our compressions, especially at our site, we use mechanical CPR. So we often see that there is LVOT obstruction, and then trying to adjust the Lucas or adjusting whatever device is on the patient is challenging. But we can see when we fix that problem on the TE, there's definitely corresponding changes in the arterial velocities that we're seeing. So I do think there is some correlation. The extent of it, I don't know, but from what we've seen, we've definitely seen a pattern where the arterial velocities will increase on the A line when we've improved our CPR.
And I think you were asking about the pulse check too. But during the pulse check, we did see a very strong correlation between peak systolic velocities and systolic blood pressures. And we decided on a systolic blood pressure over 60 because, first off, we just questioned a bunch of people in our department. When would they feel comfortable stopping doing chest compressions? And most people said a systolic over 60. And then there was this, back in the day, people used to say you could feel a blood pressure over 60 in the carotid, right? And we thought, we should disprove that.
Yeah, and I mean, I think, Mark, the real question is, is like what we're currently doing is clearly terrible. Like using your finger during a pulse check is clearly inferior. And for sure, a femoral artery Doppler might not be the end-all be-all, but I think that, you know, sure, this isn't a massively randomized, controlled, whatever, hundreds of thousands of patients, but in pig models, in real live patients like these guys have done, I mean, clearly it's superior because, I mean, I guarantee there's so many patients where we're saying no pulse, and they probably have a pulse that is probably not perfusing very well. But that goes into this question of then this thing called pseudo-PEA, right? Like, what are we supposed to be doing in pseudo-PEA? There's some pig study data that's saying that doing CPR in somebody who's in pseudo-PEA, right? So where there's cardiac contractility on your echo, but you can't feel a pulse with your finger, we call this pseudo-PEA, we might be harming them by continuing CPR in those patients rather than treating them as severe shock. So this is why it's really an important question that we really need to answer. And I think the majority of docs out there are not going to have TEE. They're not going to have the manpower to do A-lines. When I know, Mark, when you were working nights, when I was working nights, like, I'm alone. Like, it's me and my nurses. Like, I don't have residents. You don't have anybody else. And so, you know, the idea that you could use an ultrasound probe and be the pulse check and then transition to just treating severe shock, I mean, it's encouraging to me.
Well, actually, the thing that I was actually setting this up, asking you about CPR and hand placement and all that, one of the things when we were talking about TEE and using TEE to evaluate CPR quality, one of the issues was how often hand placement was in such a position as it was actually obstructing the aortic outflow. And to go to your point, JD, if someone has a very, very weak pulse and we're working them by putting pressure in their aortic tract and aortic root, you're really hurting them instead of helping them. And so that's the reason I was asking that question. Could this kind of Doppler information help us to place the hands properly, and also help us to know when to get off their chest totally? And that's what you're saying, JD, is at 60. If it correlates with 60, then certainly don't take a chance on making them backstep by compressing their aortic root.
Yeah, and we're definitely doing the same similar research here, where we're essentially trying to look at our chest compression locations and see if we can improve that peak systolic velocity in their femoral artery, because it's a more distal site. So it also tells you like how well you're perfusing the body. We think it gives you an idea of how well those chest compressions are spreading blood flow out throughout the body.
Yeah, I mean, I think here one of our biggest things is we're very big proponents of individualized CPR. We think no patient is the same, and every patient has a different body habitus, different past medical history. And I think just doing this one-size-fits-all CPR isn't the best thing that we could be doing. And I think TE and A-lines are amazing, and we love doing them. But I do think you have to be in a special shop where you have the ability and the resources to do that, which I think we do A-lines at North Shore, and it's very challenging. And we have residents, nurses, we have a lot of faculty, and it's not easy. Your patients are getting compressions. You have to kind of time it right. You don't want to interfere with CPR. So it's not an easy thing to do, and it is sort of the gold standard of what we have for compressions and knowing that we have perfusion. So I think what we're trying to do is find a simpler way to do it. We just want to make sure that it's validated.
In the flow of your resuscitation, because I'm always thinking about this, right, the logistics, right, because in my mind, at least what I've transitioned to for the moment, and I'll probably change my mind next week, I really want to get the ultrasound. If I don't have TE, I want to get the ultrasound on the heart as quickly as I can to diagnose the like newly dilated RV or the clot in transit or tamponade. Do you basically have two ultrasounds set up and you're basically assigning one resident here, you're on the femoral artery, another resident's on the TE, another resident's on the transthoracic? Is that kind of what happens at your shop?
We currently have 3 a lot of times in the room. Okay. So we have one for the TE, one for our study, and then one for the residents who are also needing to do procedures and other ultrasounds. So we bring a lot of ultrasounds in the room. It's a hectic situation, but we kind of train the residents on how to do it. And we have fellows too that also help us out. So we kind of have our own little system of how we get all the ultrasound machines into one room.
Are you guys using like the PX sonocytes? What are you guys using?
So we currently have a wide variety of ultrasounds in our fleet. So we currently have the new TEXs, and then we have some of the old Mindray machines that we have, the flat screen, the TE Maxes, I think we have as well. Then we have the GE Venues, and then we have the old school Zenaris, which we love, but they're sort of on their last leg right now. But they're still working, and we use them a lot. So we have a nice fleet in our, and then we also have some handhelds. We have the Lumifies, so we have a variety of machines that we can bring in.
Yeah, everybody has to figure out what machines which buttons where. Yeah. Sorry, Mark, I didn't mean to geek out on you. Just curious.
No, that's okay. That's fine. You know, here's where a little bit of age and perspective impacts this. You know, we started this specialty back in the late 60s and 70s as the specialty that's going to do something about cardiac arrest. Honestly, we were the guys who started CPR. I say we, not me, but I mean, it was emergency physicians who said, you don't stand there and wring your hands when somebody has a heart attack or a cardiac arrest. You get in there and you do something. And it was Seattle that was leading the way, claiming these resuscitation numbers that no one anywhere else in the country was getting. And yet they were getting, 10, 15, 20% return of circulation and people walking out the door. And it really got everybody excited, okay? And then over the course of years, people went, CPR, big deal, doesn't work. It's not really helping. If you don't shock them, if nothing works with shock, then it's not going to happen. And what you're actually doing, your cohorts, you guys are actually starting to say, if you did CPR properly, if you did it properly, our resuscitation numbers would be significantly higher because there are people who unknowingly did it in the past. And now we can actually prove and show how that CPR, the good quality CPR, can occur and can improve outcomes. And I just want to say that historically, by applying science, you're proving what our original hypothesis is that we can have an impact on cardiac arrest.
Yeah, and I think your point is
so thank you.
That we've improved cardiac arrest care a lot in the past 30, 40 years. But really, a lot of the big improvements have happened in defibrillation and shockable rhythms, and the vast majority of patients are not shockable rhythms. I think our study was only 20% shockable rhythms. So most patients are coming in PEA and asystole, and that PEA group is really an area that has a great opportunity to improve their care, especially because our study found a lot of those patients were not in true PEA, despite the clinical team thinking they were, and they were in pseudo-PEA, or they even had a pulse with a systolic blood pressure over 60 that no one could detect. So I think there's a lot of improvements that can be made in the PEA management through the use of Doppler ultrasound.
Did you guys talk about doing carotid artery, peak systolic velocity versus femoral artery?
We did. We decided not to do it because we thought it was just too crowded to do a study up at the top, up at the carotid with, intubation happening. We also use a Lucas for chest compressions in our setting. So, the Lucas kind of being in the way, transthoracic ultrasound, being there, the techs trying to get patients on the monitor. We actually video record all of our cardiac arrests. So we watch people try to do carotid ultrasounds, and it's just tight up there. So that's why we decided on the femoral, and we would be down there anyway, putting the femoral A lines in. So we thought it would just be an easier location. So yeah, we considered it.
Yeah, no, I totally agree with Dan. It's just the neck, it seems to be a lot more valuable resource, like real estate up there. And there are a lot of people doing procedures with the airway. There's respiratory up there. There's just more people up there. So we didn't want to in any way interfere with CPR. I think carotid is interesting, but femoral is just, I think, easier for us. And we're very comfortable with that view as well, the femoral artery and the femoral vein, because we're used to seeing it when we do lines. So we thought it would be the easiest to train people to do the study as well.
That being said, I mean, it is a closer location to the heart. It might be a little more sensitive for picking up flow. It's also a marker for cerebral blood flow, which is really important in cardiac arrest. I can see the benefits of doing it in the carotid as well, but we just haven't studied the carotid yet.
No, I completely agree. I mean, logistically, I assumed that was why you chose femoral. Logistically, I mean, anything up at the head of the bed, at least in my shop, it's like, it's a maze to even get there, let alone drag a machine with you.
Yeah. How many emergency departments? What's the prevalence in today's? See, I spent my entire career in community hospitals, and we've seldom ever saw mechanical compressions. It was always manual compressions. And would you say, is that just gone by the wayside? Does everybody use mechanical at this point?
At least in New York, almost all the EMS agencies have moved to mechanical chest compression devices now. There's a variety of them, but yeah, most people are coming in on them. We have 2 in our department. We've been talking a little bit about changing your chest compression locations. That is the one downside, is you can't change your chest compression location with the current mechanical chest compression devices. They're all meant to go over the lower half of the sternum like the AHA recommends.
Yeah, and just as follow-up with that, none of the mechanical CPR devices have shown any mortality benefit. I know that a lot of the EMS folks have switched to it because functionally and logistically for them, it's so much easier. Loading patients, moving patients, it like just kind of decreases the tone and the stress of the room, having the mechanical device going rather than people. And I, you know, honestly, when we use Lucas, and I enjoy it because then it's one less thing on my mind. When I've got my techs or my nurses or med students doing it, I'm like, all I'm doing, I feel like, is watching them and making sure they're actually doing appropriate depth, appropriate recoil, appropriate timing. And so it kind of is a nice offload of my mental regimen.
Are you putting in a word for making mechanical compressions more adjustable?
Yes.
We do think that would be helpful. We haven't, started studying that yet, but with the mechanical chest compression device, I will say that we have tried to move the current versions to positions like to the left of the chest where the left ventricle might be more located, and it's very challenging. Now when we decide to do, change chest compression location because of poor systolic blood pressures, poor velocities, we will get rid of the mechanical chest compression device and we will do manual.
It's pretty impossible to move the side of the compressions on the Lucas device. We've tried. Dan watches all of our cardiac arrests, and we have tried everything in terms of moving the patient, moving the device. Sometimes you'll put a blanket to try to move them that way. It doesn't work. It always just goes back to it's the same location. So really, if you want to change locations, and based on a lot of the TE literature, I think it was 40 to 45% of the patients were LVOT obstruction. So it's a pretty big group that we're not doing CPR in the right location. So I think we move to manual now pretty frequently. It's because we have the data now and we have the technology. So if we see the results that we're not getting adequate CPR, then we need to take the steps to improve it.
There's a product out there, guys. I mean, for emergency physician inventors, okay, there's a product out there that has a huge market that is not currently being adequately addressed. And I think that if you find somebody who can make an adjustable Lucas, you might have a big market.
Yeah, my follow-on question for you guys is, one of the places that I think that using peak systolic velocity, using Doppler ultrasound could be the most beneficial is potentially pre-hospital. Do you think that, in your experience, this is a skill set with let's say a Lumify or a small handheld that could be taught to paramedics, EMTs, corpsmen in the military who are in austere conditions?
Allie, take this one. She's done some studies.
No, I mean, so Dan and I were actually talking about this. We've talked about this in the past and trying how we can use ultrasound more with EMS. And it's just not a simple, easy answer, unfortunately. I think they definitely could be trained to use it, but I also think depending on where EMS is and how many providers that they have, if there's only 2 of them at the site, they have a lot of other stuff to do. So I don't know how that would go into their workflow. I think teaching them the ultrasound is definitely possible. I think you really need to make sure that you have a good training course because, like I said before, the waveforms in CPR will look very similar. So it's very easy to confuse the vein for the artery. So they really have to have good training before just to make sure they know vein on this side, artery on this side, and have some orientations in normal and just going through it with them a couple of times. But I think previous ultrasound literature always shows that if you do training courses and then refresher courses, you can learn how to do the procedure. So I think it's very doable from that standpoint. I just don't know in terms of the resources that they have available to them and what other tasks they have to do if they have time to do it. And then the other problem would be in transport, like in a moving bus, it's already hard when they're just laying on a bed and you have to hold your hand down. I don't know in terms of how their hands would move during actual transport, if that's going to be affected.
Yeah, I mean, I think one of the things that we've talked a lot about is new technologies that are being developed. Defibrillator pads weren't around in 1960s. Now they're routinely used in cardiac arrest care. So, I think Doppler ultrasound patches and things like that could be started to be used in the EMS setting to really improve detection of pulses and maybe hopefully improve detection of CPR quality as well.
Well, maybe two last questions real quick. One is, so what's next for you guys? What's the horizon for what you guys are interested in, what you're working on? What's going to be coming out of Northwell? What should I be looking for at AIUM and ASAP?
I mean, I love ultrasound and I love ultrasound research. And we love doing critical care research together. So I think in terms of the cardiac arrest population, one of the things that we touched on before is something we're very interested in is trying to determine when you have ROSC during CPR. So we looked at peak systolic velocities and we looked at flow patterns during compression. So now we're trying to see if we can kind of to try to determine if the patients have ROSC by looking at the flow pattern. So we would know maybe who do we need to stop compressions for and who do we continue CPR for. So to eliminate doing a pulse check in a patient that we know doesn't have ROSC, just because as we've seen before, compressions are really the most important thing in high quality CPR is what improves survival rate. So if we can eliminate stopping and those opportunities for interruptions that could delay restarting compressions, it's something we're very interested in doing.
Yeah, especially for those PEA patients that we were mentioning earlier. The point of these 2-minute interruptions in CPR is to check for a shockable rhythm right now and to get them out of it. But again, 20% or so of our patients are in that shockable rhythm. So for those PEA patients, maybe extending their intervals to longer periods of time, if you can detect ROSC reliably with an ultrasound machine, would be really great and really improve chest compression fractions and hopefully outcomes.
So then I gotta ask a quick follow up to that. So if you find somebody, let's say you do your pulse check and you've got somebody at peak systolic velocity of 12 or 13, are you calling that pseudo-PEA and holding compressions? Are you continuing compressions? What do you guys I know that we really don't have a definitive answer to that right now with the current literature, but what are you guys doing at your shop currently?
So I guess everyone's a little bit different. I tend to err on the sides of if it's the peaks, I'll call it pseudo-PEA and I'll start Levophed at that time. And then it just sort of depends. A lot of times I will continue compressions if I feel like it's a pseudo-PEA, but they still don't have really adequate perfusion because we also have an echo going usually at the same time. So I can see, all right, there's squeeze, but it looks like very low VTIs or very low output. So they probably still need a little bit of help. So while we're getting the Levophed going, at least I continue compressions until that time.
Yeah, and I still do the same. Less than 50, less than 60. I'm still continuing doing chest compressions. And just anecdotally, we haven't looked at this either. We have seen that those people who start out with very low flows and they start getting better flows, as you do high quality chest compressions, you start giving them more meds, you start them on norepi, eventually you get them their peak systolic velocities high enough to stop CPR.
Very cool. What did we miss that we should have asked you that we didn't?
We thought we were gonna get to bring up our future research plans here, but you guys started off with those, so surprising.
No, we love ultrasound and we love improving cardiac arrest. And I think the first thing that we're always emphasizing is going away from manual palpation and really going towards Doppler. I think the technology is there, and I think based on our study alone, where it's basically flipping a coin, if you feel a pulse, we can do better for our patients.
Yeah. Are you guys a part of the Resuscitation collaboration? Are you guys contributing to their registry?
Yeah, we are. We're definitely behind if Felipe is watching on submitting data, but we've been going through it and we'll update it all soon.
Nice. That's great. I love it. It's good stuff.
Well, I hope you've enjoyed today's show. We've certainly learned, if there's nothing else, that we should be looking hard at improving the quality of our CPR and showing how that, in fact, doing various things, ultrasound evaluation of peak systolic flow is going to be one of those things that's going to encourage you and guide your therapy. So I hope you've been benefited by talking to these two researchers. Allie, Dan, thank you so much for joining us. And I hope that for the emergency physicians who hear this, that you're encouraged and you see that there is improvement on the horizon and that we will make a larger impact on these patients than we ever have before. Thank you for joining EP Talk.